Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. My name is Zak Kaesberg. I'm your tutor, your coach, your guide along the path to passing the CDR exam. My biggest passion is to help RDs and RDs to be just like you to know how to effectively pass. And if that sounds like you, then hey, you're in the right place. Today, I want to take some time to do medical nutrition therapy together, and it's in particular a concept that I really love. It's the pancreatic biliary area. Now, this is an area we learn about in digestion and absorption, and what's so cool about it is those concepts tie so closely in to what they have to do with for medical nutrition therapy. In fact, those functions that they have really impact MNT in the patients we work with. Today, we're going to talk about the gallbladder and the pancreas a little bit, talk about the diseases of them, their function, and give you just some background a little bit as to what and why it happens. The gallbladder is a tiny green sac, and what it holds is bile. Whenever I think of the gallbladder, I think of a bladder and how bladder normally holds liquids or urine, right? Well, that's what the gallbladder is doing. It's holding liquids, but in this case, it's holding bile or bile salts. Those bile salts are being synthesized from the liver and then deposited to be stored inside the gallbladder. Really interesting, right? It's really good to know that the gallbladder is going to store those things, and it's also good to know that the gallbladder has a bile duct. It's like a little duct, a little street that merges off, and it actually meets with another duct. It's called the pancreatic duct. So you just heard me right. There's a bile duct that meets up with the pancreatic duct, like they're meeting on a street. The bile that is secreted from the gallbladder is secreted into the small intestine in response to presence of food, particularly. Because those bile salts help with breakdown of fat in the small intestine, makes them more digestible, easier to form into chylomicrons, and pass through the membrane. In order for the gallbladder to completely contract and let out all of those bile salts, we have to make sure that we know that CCK is a hormone from the small intestine that is coming to the gallbladder and saying, "Hey gallbladder, you need to go to work now." So basically CCK is making the gallbladder contract, and also the presence of food is all working together here. Now we're going to come back for diseases of the gallbladder. Right now, I want to make sure we're looking at the anatomy and understanding this whole picture. You heard me earlier. The gallbladder has a common bile duct, which merges with the pancreatic duct. This all terminally ends inside the small intestine. This point is going to become very important later, so I wanted to make sure we emphasized it. Now, let's talk about the anatomy of the pancreas. The pancreas is a huge accessory organ for digestion and absorption. We know the pancreas has both exocrine and endocrine functions. If you've ever had trouble with those concepts, remember, exocrine is outside the body, endocrine is inside the body. Another helpful trick is that if someone needs to get treated for their diabetes, they go and see an endocrinologist, right? That can be helpful to tell you that endocrine should make you think of insulin synthesis, glucagon synthesis of the pancreas, much of those hormones that we really talk about there for those endocrine functions that we think about. One more I might throw in there is also somatostatin that can be released from the delta cells of the pancreas to help regulate the amount of absorption of food in the small intestine, alter glucagon and insulin secretion, as well as kind of tell our small intestine to, hey, slow down, inhibit CCK, inhibit secretion, which are other hormones involved in small intestine. That ties up most of the endocrine. Now let's talk about your major exocrine functions, because that's actually what we're going to spend a lot of time talking about today. The actual function in the liver, of the pancreas is going to be all of those enzymes that it makes. The enzymes that we would be thinking are enzymes that digest carbs, fats, and proteins. Those all come from the pancreas. The names of those, respectively, are pancreatic amylase, pancreatic lipase, chymotrypsin, and trypsin are those last two that are involved with protein. They're zymogens, that's what they're known as, kind of protein digesting enzymes. That's what we think of for that. The other two, of course, salivary amylase would be for carbs, salivary amylase. Let me say that back. Pancreatic amylase is going to be for carbs, pancreatic lipase would be for fat. So, those are major exocrine functions of the pancreas. One more thing to mention: the pancreas also releases pancreatic bicarbonate. Pancreatic bicarbonate is what is neutralizing that stomach acid. As that acidic chyme comes in, the pancreatic bicarb is what is going to neutralize that. And a reminder for you: the hormone secretin is responsible for the secretion of pancreatic bicarbonate. Whereas CCK, cholecystokinin, which we just talked about with the gallbladder, that one's going to be responsible for the release of the enzymes from the pancreas. So the secretin is going to be doing the bicarb, CCK is going to be secreting those enzymes. So it's important up to this point that you're understanding the major functions of these organs, the anatomy, and the ducts that they share. Now it's time to bring everything into play. Okay, we're going to start with disorders of the gallbladder, and for each of these, we're going to talk a bit about the pathophysiology of the disease, medical management, and especially our medical nutrition therapy if there's some indicated. Cholelithiasis. This is another word for saying gallstones. Gallstones form within the gallbladder or in the biliary duct system. The idea of gallstones is mostly that it's being caused by high levels of cholesterol. That's one of the really common things that'll happen here. Secondly, being pigments, and three, being mixed stones of different origins. But with the cholesterol, people who eat too much cholesterol will have too much cholesterol in their blood, and the bile itself becomes very dense in cholesterol. That high amount of cholesterol in the bile ends up crystallizing, forming little microscopic cholesterol crystals and calcium salts. There are other several things that can fit into why gallstones happen: ethnicity, history of pregnancy, history of weight loss or dieting. These can also impact gallstones, but typically they're being caused by the cholesterol in most cases. Now, symptoms of gallstones that would include things like nausea, vomiting, upper quadrant pain after meals, and this would especially happen after fatty meals, which makes sense because we know that the gallbladder is probably really trying to work to break down those fats, but if it's impacted or there's a stone in the way, it's not going to do it, right? On the side of medical management, a lot of the times gallstones are going to be diagnosed using x rays or CT scans, but the most common treatment is surgery. So, surgical removal of the gallbladder. Cholecystectomy is a complete removal of it. That's the most common way that they will treat severe gallbladder issues or gallstones. For the MNT, when working with a patient with cholelithiasis, you would, of course, start with your assessment, right? You would explore if the patient has had any recent weight loss, decreased PO intake, diet history, and/or tolerance to foods and beverages. You certainly want to make note of any previous medical treatments, previous medical history they have that relates to their gallbladder or the pancreas or anything involved there. For diagnosing this patient and forming that PES statement, we would probably be exploring things related to any possible weight change, changes in PO intake. I also think we could argue a bit of a problem statement of altered GI function, since this would fit into the clinical domain of problem statements. And due to the high level of inflammation and stress, I think we could also pop this patient for increased nutrient needs or malnutrition if they were really severe enough. Now, the nutrition therapy for this condition, it's just going to be a low-fat diet, moderate protein. We recommend these patients take small, frequent feeding several times throughout the day to improve their total nutrient intake, but also avoid exacerbating the gallbladder. With the moderate protein, I imagine that they're just thinking, hey, don't eat too much protein, animal proteins, high cholesterol items, because if you get gallstones once, it's probably likely that you're going to get gallstones if you still have your gallbladder left. All right. So now that we kind of talked through that a little bit as we go through it, we're going to be kind of moving on a little bit to a little bit more of some of the different things that we think would be required here. So for our next condition, what we're going to kind of be going through is we're going to start by going through pancreatitis. Love pancreatitis. Pancreatitis is one of my very, very favorite types of conditions to talk about. One of my first major case studies was a patient with pancreatitis. So it's really, really cool to talk about. Pancreatitis is inflammation of the pancreas. In case anyone needed to hear that out loud, Pancreatitis also has multitudes of etiologies, most common being gallbladder disease, pancreatic cancer, alcoholism, smoking, hyperlipidemia, and obesity. These all can be really, really common ways. Now, with pancreatitis, we want to remember a little bit about those important functions of the pancreas. So let's remember those that we talked about earlier. We had those exocrine functions where the pancreatic amylase, pancreatic lipase, and those zymogens, those proteases like chymotrypsin and trypsin, are being released when food comes into the small intestine, right? Under normal circumstances, that food comes into the small intestine, CCK comes from the small intestine, signals to the pancreas and says, hey, you need to release those enzymes. The pancreas releases the enzymes and we digest and absorb everything. That's what happens when it's normal, right? What happens when it's abnormal? About a third of all pancreatitis symptoms, not symptoms, pancreatitis in general, is being caused by gallbladder disorders, specifically gallstones. Remember when I was talking about how important it was to understand the anatomy of that biliary duct and how it's shared with the pancreatic duct? This is why. If I have a gallstone that's up here in my kind of gallbladder duct and it travels down to that biliary duct, it's going to meet right where that pancreatic duct and that biliary duct are meeting, like a street, basically, right? If I have a stone and it gets stuck on that street, nothing is going to be passing through. So it's like everything's blocked off now. So what happens is if I have a stone in the way of my pancreas and of my gallbladder, and I eat food, well, my body says, hey, we need our pancreatic enzymes. So the pancreatic enzymes attempt to get released, but they can't go anywhere, can they? Where are they going to go if there's a big gallstone in the way? So they start doing what enzymes do. And what do enzymes do? Enzymes break things down, right? So in pancreatitis, those enzymes that usually are breaking down your food, those same enzymes get trapped in your pancreas and they start to digest your pancreas, which is why I find pancreatitis so fascinating, because under normal circumstances, those enzymes would be very beneficial. And in this case, when you eat food and you have some type of obstruction, those enzymes start digesting yourself, which is really fascinating to think about. They should go into the small intestine, start digesting, but it starts digesting itself. So really, really cool, interesting condition. It's so weird what the body can do. Okay. Now let's talk about signs and symptoms. With pancreatitis, a patient is normally going to have abdominal pain that can be very serious or mild. They tend to have nausea and vomiting associated, pretty poor PO. They're probably going to have increased temperature and maybe some hypovolemia. Their levels of serum lipase and serum amylase become elevated in the blood because the pancreas isn't able to release it into the small intestine. So, in some ways, that serum amylase and serum lipase ends up getting almost dissipated to the blood and other areas because it doesn't end up where it should be. So, you can see elevated levels of those in the blood too. Let's take a quick pause here. For the exam, we need to understand the difference between acute pancreatitis and chronic pancreatitis in terms of treatment. Acute pancreatitis is brought on by acute, short-term issues. Chronic pancreatitis is over a really long period of time. When we talk about acute pancreatitis, what we're talking about is this could be the first time this has happened, or first of a couple times, or maybe it's been 10 times that they've had this issue, right? However, I would argue it's still an acute issue, right? It could resolve itself. It's not meant to be permanent damage forever, and you're supposed to be able to go back to some normal function. That's what you'd think. Chronic is much more severe, though, and there's much more long-term decreases in function and other comorbidities that can follow. Excuse me. So I want to continue by talking about acute pancreatitis and its treatment and then shift to the chronic, okay? A patient with acute pancreatitis is under a significant amount of metabolic stress for that acute period, so they should be considered at high nutrition risk when you're doing your assessment. When they come to you, they may have issues of alcoholism, drug use that may have also affected their PO intake prior to admission. For medical nutrition therapy, we want these patients to have those with acute pancreatitis to meet their calorie needs, maybe using a standard of 25 to 35 kilocalories per kilogram to meet their energy needs. So, pretty much to the moderate to high. Additionally, protein requirements range from 1.2 to 1.5, so I would say that's about moderate protein required for this condition. And we would want these patients to choose an overall low fat diet because it tends to be better tolerated, they get less release of that pancreatic lipase, and their system tends to tolerate it much better. So, this is the good news. If this patient is able to eat orally, we would prefer them to eat orally. If they're unable to meet their needs orally during that acute pancreatitis, we would recommend early enteral nutrition initiation within the first 24 to 72 hours of hospitalization. For nutrition support, we would much prefer enteral nutrition instead of parenteral nutrition. Another pause. Where to feed a patient enterally and where to place the tube has been and is still under debate for a long time. I have one textbook that says gastric feeding is the best feeding. I have another one that says jejunal feedings are optimal. And I've read two journals now that are from only a few years back that says it's up for debate and we don't know the best answer. I don't think they know, everyone. Here's the truth. I don't think they know. But I do want to give a kind of what I would say how we would approach questions in this way and say, we need to start tube feeding within the first 24 to 72 hours, okay? Especially if they're at high risk for malnutrition, we should do that. That's what the best guidelines say is initiate tube feeding early so that we can avoid malnutrition. If they could tolerate gastric feedings, whether it's orally or enterally, then yes, of course. Why would we not feed them gastric, right? Because if they can tolerate it, we would have no need to do anything else. We would feed them into their stomach. You all agree with that, I do feel. But if they could not tolerate into the stomach, we could feed them into their jejunum. We could place a nasojejunal tube for short-term feedings and feed them into the jejunum. Because remember, if you think about the anatomy of the small intestine, you have your duodenum, jejunum, and ileum. The duodenum is way up here towards the pancreas. So the thought is if you feed into the jejunum, you are going to skip the pancreas. And you're not going to have to get that big release of pancreatic enzymes that you would normally get if you fed into the stomach or the mouth. Okay, so that's the whole mindset here. The reason they say jejunal feedings might be better is because they think if you don't stimulate the pancreas, it's going to help the pancreas to relax. And if a question were posing it like that to say which feedings would be most optimal for pancreatic rest, I'd probably say jejunal feedings. If they said what is best, well, I'd say, well, let's try gastric and then let's move on to jejunal if they couldn't tolerate it. Because that's what we would do really in that case anyway. Unless there was a huge gastric issue, we would probably try to feed them in their stomach and see if they could tolerate it. And if you think about it, you technically do that orally anyway. You're trying to see if they can eat orally and use their stomach. So that might seem confusing to a few of you, and I apologize if it is. I don't have a perfect answer on it, and I wish I did especially for questions and for the exam. But I think what I just gave is a good breakdown of how I think we can approach things most optimally. Chronic pancreatitis. There's an uncontrolled inflammatory response to the body. On top of acute pancreatitis, chronic pancreatitis ends up becoming fibrotic and calcified. So it's almost like the liver going through cirrhosis. It's showing a very great decrease in function. One of those functions is going to be reduced ability to produce or release those pancreatic secretions and enzymes. We might not even make them at this point. So it's not an issue of releasing them. You might not even be making them at that point. So then we're not going to digest things very well during digestion and absorption. Another thing is we're going to have a decrease in our endocrine functions of the pancreas. So, insulin, glucagon, we're probably not making those so well. And this can in turn lead to diabetes and poor blood sugar control because they're not having insulin and glucagon. Really scary, right? When you think about that. For symptoms, a couple things for chronic pancreatitis would be like abdominal bloating, abdominal pain, steatorrhea, which is going to be fattiness in the stool due to the lack of pancreatic lipase to help digest your fats. Okay. So keep in mind all of those decreases in functions that happen with chronic, but maybe not acute. On the medical side, a medical team would be working to reduce and modify the behaviors that might exacerbate someone's pancreatitis and other symptoms. Use of pain management and surgical resection is really commonly used for pain control. We would also want to try to manage the patient's steatorrhea, diarrhea, weight loss, vitamin mineral deficiencies that they're quite likely to show. And remember how I talked about that decrease in insulin and glucagon? Well, that might require type 2 diabetes and following up with an endocrinologist and getting on insulin, for instance. Now, an assessment of this patient, you're going to be assessing them for malnutrition, including a nutrition focused physical exam. They're likely to have weight loss as a related symptom and also going to have decreased PO intake. With this being an inflammatory disease, you want to look out for your inflammatory markers. Remember, you have your negative acute phase reactants, such as albumin, prealbumin, transferrin, and those should be checked to monitor inflammation. You would also look at your positive acute phase reactant of C reactive protein to see if it went up. As well, the text mentioned glucose, triglycerides, BUN, creatinine, and white blood cells should all be monitored on the patient. The MNT on a patient with chronic pancreatitis is not going to be that much dramatically different than acute. Calorie needs are going to be increased, 35 kilocalories per kilogram to meet their needs. For protein, we still want to provide 1.2 to 1.5, same as acute. We want small, frequent meals and moderate amounts of fat. Definitely not high fat. They say moderate amounts of fat, and my reasoning probably is they want patients to meet their calorie needs. And if you do low fat, it's going to be very difficult to do that. So it's not a low fat, it's moderate, and it's not high. It's somewhere in the middle, okay? Now, to finish up this concept, I'd like to talk about a little thing called PERT, okay? Pancreatic enzyme replacement therapy, or PERT. These are supplemental enzymes that are provided to a patient with chronic pancreatitis that allows them to break down macronutrients and absorb them. Vitamins and minerals that are all tied up and associated with those fats and those proteins. If we don't have enzymes, they're probably not going to get released for them. So we'll give them PERT enzymes to help them with an oral diet to help them to have like a normal life, normal function, eating normal types of foods. And of course, if nutrition support was indicated for these patients, we would prefer an oral diet followed by a gastric diet, enteral, and then the very last thing we would ever want to do would be parenteral nutrition if we felt like it was warranted, but we would try several things before we got to that point. Now let's apply this to some practice questions. Number 1, which of the following is considered an exocrine function of the pancreas? A, release of cholecystokinin, B, synthesis of insulin, C, synthesis of glucagon, or D, release of pancreatic bicarbonate. Which of the following is considered an exocrine function of the pancreas? Let's use process of elimination to help us out. A, release of cholecystokinin. This is not something I'm going to associate as an exocrine function of the pancreas. It's related, but the cholecystokinin does not come from the pancreas. It comes from the small intestine. So that means I need to rule out answer A. B, synthesis of insulin. Okay, this is a function of the pancreas. However, we need to remember that people get treated with diabetes and go see an endocrinologist. We're looking for an exocrine function. So I'm going to rule out answer B. C is synthesis of glucagon, and this being a hormone also would apply with endocrine functions. C is not going to be a good fit. D is release of pancreatic bicarbonate. This is a true exocrine function of the pancreas. And for which of the following is considered an exocrine function of the pancreas, I would pick answer D, release of pancreatic bicarbonate. Number 2, which of the following would be the appropriate nutrition intervention for a patient with chronic pancreatitis? Would it be A, high protein, high calorie, high fat diet? B, high calorie, high protein, moderate fat diet? C, consistent carbohydrate diet, high protein, low fat? Or D, low calories, low fat, high fluid? Which of the following would be the appropriate nutrition intervention for a patient with chronic pancreatitis? For A, high calorie, high protein, high fat. For this one, I do like the calories, the protein. However, I find the fat to be a little bit odd. I don't think that would be a good answer because the fat would overdo the pancreas, and we don't want high fat. I'm going to rule out answer A. B, high calorie, high protein, moderate fat. This seems like a good answer for chronic pancreatitis. I know in acute, they wanted low fat, but in chronic, they might want them to meet their calorie needs a little easier, so moderate fat might be best. I'm going to put a check mark by that one. C, consistent carbohydrate, high protein, low fat. Well, if they have diabetes, consistent carbohydrate would definitely be good. I don't know if it's indicated here. I might just put a question mark for now. In D, low calories, low fat, high fluid. Definitely don't want low calories for someone with pancreatitis because they are at high nutrition risk. I would rule out answer D. So, for which of the following would be the appropriate nutrition intervention for a patient with chronic pancreatitis? My best answer here is B, high calorie, high protein, and moderate fat. Number 3, a 25-year-old with past history of drug and alcohol abuse with multiple hospitalizations is admitted for acute pancreatitis. He has poor PO intake 5 days prior to admission. He shows signs of protein malnutrition and has had a 9% weight loss in the past 3 months. The patient should be recommended to meet their needs via what? Okay, for A, parenteral nutrition. B, NPO for 72 hours, then continue with oral diet. C, placement of gastrojejunostomy tube and initiation of feeding within 24 to 72 hours. Or D, placement of nasogastric tube and initiation of feeding within 24 to 72 hours. Okay, let's work through the question. 25-year-old, drug alcohol abuse, multiple hospitalizations, currently admitted for acute pancreatitis. Let's go through his nutrition assessment. He has poor PO intake 5 days prior to admit. He shows signs of protein malnutrition. He's had 9% weight loss in 3 months, which is significant. 7.5% would be the cutoff for 3 months, so he's showing signs of severe malnutrition right now. And it's saying, how should we feed him? So when it comes to this RD2B, I want you to think through and get rid of your bad answers first. Don't even think about those. So with A, it says parenteral nutrition. I see no reason why we need to feed this patient parenterally. We can use the GI tract in some way, and I would rule out answer A. B, NPO for 72 hours, then continue with an oral diet. Well, given an oral diet, it's not a terrible idea if he can do it. Only problem is NPO for 72 hours is so overkill. He's already probably severely malnourished. 3 more days NPO is going to make him more malnourished. It's not going to be helpful. So B is not an appropriate answer. C, placement of a gastrojejunostomy tube and initiation of feeding within 24 to 72 hours. So this would mean we're going to place a tube that he's probably going to keep there for about 3 months. Or D, placement of a nasogastric tube and initiation of feeding within 24 to 72 hours. If I'm stuck between C and D, C is going to be a long-term use of nutrition support. D is going to be short-term. I don't have any indication that he's not going to be able to rebound in some way, and I don't have an indication that says he needs to be on tube feeding for 3 months. It also is based on that I would say The D, placement of a nasogastric tube with initiation feeding within 72 hours. That would be my best answer, 24 to 72 hours, because I think then we could try this out at a low rate, see how he tolerates it. And with C, if he's going to be on it for 3 months, then great, but I don't think he's going to need it for that long, and we don't have an indication that he will. D is our best answer for number 3. That wraps up today's lesson, students. I hope you watched, listened, learned, and enjoyed today's show. Remember that passing this exam is a journey. We all need assistance along the way. Do me a favor, hit the subscribe button, tell other studying students, rate, review, help spread the word. And remember, as always, happy studying to you, RD to be.